Welcome everyone to our Medical Informatics Grand Rounds for our beginning first year students. And this is our first Grand Rounds of the year, so we're so excited that you are all here. To our listeners and viewers that are watching from our live link, welcome. This is a Grand Rounds case, and our first year students will be presenting the first time they've ever done this. 4, 5, 6 weeks into medical school, and they are presenting a Grand Rounds case. They have done all the research on this, and without further ado, we would certainly like to start our first Grand Rounds. Thank
you. Well, thank you, Ms. Fitterling. Good morning. Welcome to Grand Rounds. We are Group 1 presenting a Medscape case of a blistering rash in an 84-year-old. This is the members of our team. And my name is student Dr. Patrick Brennan, and I'll be walking you through the history, presentation, as well as differential diagnosis of our patient today. Chief complaint of our patient is that of a blistering rash. All right, the history of present illness is that the 84-year-old female presents with a blistering rash for a duration of 1 week. This rash began on her right hand, traveled up her arm, across her upper chest, and then through her abdomen. It is a painless rash, but is intensely pruritic. It's also known as itchy. No fever with our patient, and she also reports no history of trauma or recent travel. Despite an extensive medication list, which we'll discuss in a moment, she reports no changes to her meds or to her adherence to the program. Her past medical history is notable for non-metastatic breast cancer, which is 100% estrogen receptor positive. She also has ischemic heart disease, osteoporosis, chronic renal insufficiency, as well as hyperlipidemia. Medications include daily use of aspirin and isosorbide mononitrate, as well as ramipril, which is an ACE inhibitor, all to combat her ischemic heart condition. She takes simvastatin daily to combat hyperlipidemia, as well as alendronate and a calcium supplement to help support her osteoporosis. Her breast cancer is being treated by an aromatase inhibitor, and again, she reports no changes in current medications and no use of over-the-counter or herbal supplementation. Her social history is that she lives alone. She has very limited mobility, so she relies on the use of an electric scooter, and she also relies on the help of friends and family for her assistance with the activities of daily living. Her physical exam findings are shown in the chart above and can be considered normal for a patient of our age. Her review of systems is that of a general appearance of a frail woman. However, she appears in no acute distress. Her cardiovascular exam reveals a regular rate and rhythm. However, a loud S2 sound is heard upon auscultation without murmur or gallop. Her pulmonary exam reveals that her lungs are clear on auscultation with clear and equal bilateral breath sounds. Her GI exam reveals that her abdomen is soft and non-tender, and no hepatosplenomegaly is detected. Her breast exam reveals a 3-centimeter mass underlying the nipple of her right breast. The skin is puckered in this area, however, no lymphadenopathy is detectable, and these findings are also consistent with her last documented breast exam. Her skin reveals vesicles with several tense bullae across her right arm, chest, and abdomen, and these bullae and vesicles rest on an erythematous base, right, and they're filled with a clear fluid. Further inspection reveals no involvement of her mucosal membranes, as well as her Nikolsky sign is negative. A Nikolsky sign positive Nikolsky test would be if you gently rub the skin, it would peel back and form a blister within a minute or two. Now, we're going to talk a lot about skin lesions today, so I want to take a moment to just describe a couple of them for you. In the top left corner, you would see what would be considered a macule, which is a non-raised, non-elevated skin discoloration. Below that is a papule, which is an elevated skin lesion measuring about a half a centimeter and less in diameter. Now, vesicles and bulla are quite similar in their presentation, in that each are elevated skin lesions that contain a clear fluid. However, vesicles are about a half a centimeter in diameter and less, whereas a bulla or a blister would be a 0.5 centimeter in diameter and larger. Right? A pustule is a pus-filled lesion, and a scale is that of a palpable raised epidermal grouping of cells. Right? So with a review of our patient's history complete, we begin to think about our differential diagnosis. First, we think about our drug-induced, first one we want to explore is drug-induced eruption. We also think about herpes zoster, also known as shingles, pemphigus vulgaris, and bullous pemphigoid. Now, drug-induced eruption, the clinical manifestation of a drug-induced eruption is that typically of a solitary rash, generally first appears on the thin skin around the lips or genitalia, and can be delayed from up to 2 weeks from a change or introduction to a medication. Now, symptoms are both local and systemic. Local symptoms include pruritus or burning or a painful rash, whereas systemic symptoms would include a fever, malaise, nausea, diarrhea, or abdominal cramping. While drug-induced eruption can take place with any type of drug, it is more commonly seen in drugs in the sulfa and penicillin families. Here's a typical picture of a erythematous base with some vesicles starting to form and a drug-induced eruption rash. Next, we'll talk about herpes zoster, also known as shingles. Clinical manifestation of herpes zoster is that of a reactivation of a dormant varicella zoster virus that is dormant in the dorsal root ganglion. Upon reactivation, the virus will spread through the periphery and sensory nerve ganglion and follow a dermatomal pattern. Right, this rash is incredibly painful, bordering on debilitating, and it is unilateral. Shows a red maculopapular eruption in the beginning and will evolve into mature pustules. Now, T1 to L2 dermatomes are the ones that are most commonly affected. However, it is important to note that any dermatome is possible to see a herpes zoster eruption. Now, this typically presents in patients over the age of 50 with a positive history of varicella virus. Oops. And here's a photo of herpes zoster, where you can see a clustering of vesicles here and eruption into more mature pustules. All right, pemphigus vulgaris is an autoimmune condition. All right, its clinical manifestation is that of intraepithelial blistering in the mucous membrane and skin. Right, these blisters will be flaccid and fluid filled with clear fluid. This here is a picture of pemphigus vulgaris with a bulla here, as well as exposed skin from an excoriated blister. And then bullous pemphigoid. So the clinical manifestation of bullous pemphigoid typically presents in patients over the age of 70. This can be a subacute or acute onset with widespread tense blistering. It's painless, but it's incredibly pruritic and typically spares the mucous membranes. And a photo of numerous tense bulla and bullous pemphigoid. So with our differential diagnosis complete, we can begin to order lab tests centered around our differentials today. And the first one we decide to run is a complete blood count with a differential. Right? This reveals an elevated eosinophil count versus a reference range bordering on mild eosinophilia. Our hemoglobin level is 12.7 grams per deciliter. Our complete metabolic panel was also, we ordered a complete metabolic panel also, which revealed a blood urea nitrogen of 28 milligrams per deciliter, as well as a creatinine value of 2.1 milligrams per deciliter. Both of these are confirmatory of her past medical history of chronic renal insufficiency. Her liver function test came back as unremarkable. Her inflammatory markers were also not elevated, which were her erythrocyte sedimentation rate as well as her C-reactive protein levels. Her anti-nuclear antibody test was also negative, which is a marker for autoimmune function. We also decided to order swabs of both bacterial and viral activity of the exudate of the blisters, and both of these came back negative as well. We decided to order some tissue sampling and fix the tissue and stain it with H&E, as well as perform direct and indirect immunofluorescence. Tissue sampling fixed with H&E reveals the eosinophil-rich infiltrate, as seen in the circles on the right-hand side in a subepidermal blister. Now, immunofluorescence can be done in two ways, both direct and indirect immunofluorescence. Both require the use of a conjugated antibody conjugated with a fluorochrome, whereas direct immunofluorescence utilizes a primary antibody, and indirect utilizes a secondary antibody. Now, we're running this test to help us narrow down between bullous pemphigoid and pemphigus vulgaris. Right? Bullous pemphigoid will show a linear deposition of IgG along the basement membrane. And will not penetrate the epidermal layers, whereas pemphigus vulgaris will show a diffuse pattern of anti-IgG throughout all layers of the epidermis. With our testing complete, brings us back to our differential diagnoses, and we can begin to rule these out at this point. So we can rule out a drug-induced eruption as the cause of our patient's blistering rash due to the fact that her medication and adherence to said medications has not changed, and also the lack of systemic symptoms. We can also rule out herpes zoster, as the main clinical manifestation of herpes zoster is that of an incredibly painful rash, and our patient's rash is non-painful, only intentionally pruritic. Also, viral activity in the exudate of a blister was negative, therefore ruling out herpes zoster. Which brings us to pemphigus vulgaris and bullous pemphigoid. We can safely rule out pemphigus vulgaris at this point because one of the hallmarks of pemphigus vulgaris is the intraepithelial blistering of the mucosal membrane, as well as a positive Nikolsky sign, both of which our patient did not have, bringing us to our final diagnosis of bullous pemphigoid. For further discussion of our differential diagnosis, the basic science behind that, and the treatment options for our patient, I'd like to introduce student Dr. Josh Beckler.
Thank you, student Dr. Brennan. As my colleague stated, my name is student Dr. Josh Beckler. And now that we've established our case and reached a final diagnosis, we're going to transition into discussing some of the specifics of the disease process, treatment options for our patient, ethical considerations, emerging research, and then we'll close with some concluding remarks. Bullous pemphigoid is an autoimmune blistering skin disorder, specifically a member of the pemphigoid group. As seen by the images on the screen, these patients typically experience tense, fluid-filled bullae that are oftentimes present on an erythematous or urticarial base. And this base is particularly present in that center image, as well as the one on the right here with that erythema. In the United States, bullous pemphigoid accounts for just over 3 out of every 100,000 hospitalizations per year. And as student Dr. Brennan said, this is a disease that predominantly affects the elderly populations, where we see an increased incidence in populations over the age of 60. The diagnosis of bullous pemphigoid can be clinically established when 3 of the 4 diagnostic criteria are met. Patient age of over 70 years old, absence of atrophic scars, which are sunken or depressed areas of the skin resulting from damage to either collagen or adipose and subepithelial tissues, absence of mucosal involvement, or absence of predominant bullous lesions on the head and the neck. And it should be noted that our patient today did indeed meet all 4 of these criteria. Bullous pemphigoid as a disease typically runs a waxing and waning course in which its clinical progression can be divided into 2 distinct phases. The first of these phases is a non-bullous prodromal phase. As seen by the image here, this patient is experiencing pruritic, eczematous, and urticarial lesions. These can be either localized to a specific area of the body, as in this image, or they can be widespread on the surface of the patient's body. And they typically precede blister formation by days and even up to months. It's also important to note that there is no mucosal involvement in this stage either. The more classical picture of bullous pemphigoid is that of the bullous phase. As you can see on this image, this patient is experiencing multiple stages of bulla and vesicles. We can see a tense fluid-filled bulla here, here, and a few of these vesicles, the smaller lesions here and here, as well as some open wounds that have erupted, erupting blisters producing open wounds and open sores. That erythematous urticarial base is also present, which was initiated by the prodromal non-bullous phase. It should also be noted that these lesions are commonly observed on extremity flexors, trunk, and the thighs of the patient with still no mucosal involvement. As far as disease mechanism, bullous pemphigoid is a type 2 hypersensitivity that targets protein components of the hemidesmosome. It's important to remember that hemidesmosomes anchor the basal layer of keratinocytes to the basement membrane at the dermal-epidermal junction. So, on the schematic on the screen, we have our cell, which is most likely a basal keratinocyte. Then in the extracellular matrix, we have our basement membrane composed of collagen, as well as linker proteins such as laminin. And then the structural complex joining these two is our hemidesmosome. In bullous pemphigoid, there have been two main autoantigens that have been identified. The first is bullous pemphigoid antigen 1, and it's identified on the screen. It also goes by the name BP230, specifically for its molecular weight. This is an intracellular component of the hemidesmosomal plaques that ultimately link hemidesmosomes to the keratin cytoskeleton of the cell, granting structural integrity to this layer of cell as well as the epithelium as a whole. However, although autoantibodies are observed to this antigen within bullous pemphigoid, because of its intracellular nature, it's thought to be a secondary event. The predominant autoantigen in bullous pemphigoid is that of bullous pemphigoid antigen 2, and it also goes by a more descriptive name, type 17 collagen. As seen on the screen, this is a transmembrane protein that extends from the cell surface into the lamina lucida of the basement membrane, where its collagenous domain can then bind with linker proteins such as laminin. It's important to remember that in those direct immunofluorescence studies that student Dr. Brennan showed, this is the antigen in which those autoreactive IgE antibodies are targeting and why we get that linear deposit. I mentioned the fact that this is a type 2 hypersensitivity, and it's important to remember that this mechanism is mediated by the patient's own antibodies directed against the patient's tissue. The predominant antibody class in bullous pemphigoid is that of IgG, and this is significant because of its ability to activate the classical complement pathway. This can directly lyse cells via the membrane attack complex, as well as produce a variety of pro-inflammatory mediators. That's what's being shown on the schematic to the right. We have autoreactive antibodies targeting that bullous pemphigoid antigen 2, or type 17 collagen, initiating the complement pathway, and then inflammatory mediators resulting in the migration of neutrophils and eosinophils, and ultimately the formation of a blister. IgE antibodies have recently also been highlighted as essential for the formation of the prodromal non-bullous phase. As we can recall, IgE is typically not found in high levels in serum because of the fact that it is bound to mast cells rapidly and with high affinity via the Fc epsilon receptor. When these receptor-bound IgE antibodies cross-link when they bind to their autoantigen, bullous pemphigoid antigen 2, these mast cells degranulate, initiating a local inflammatory response, essentially that prodromal phase, before the blisters begin. But let's get back to the clinical side of things. We treated our patient ultimately with the high-potency topical corticosteroid clobetasol propionate. This is a synthetic glucocorticoid that has diverse immunosuppressive as well as anti-inflammatory effects. Our patient experienced good results, and ultimately her rash went into remission. And for this reason, we tapered the dose of her corticosteroid over several weeks. For osteoporosis, it's important to note that we continued her calcium and vitamin D supplementation, as steroid usage can eventually worsen osteoporosis. There are a few additional treatment options that we did consider, the first of which is oral corticosteroids such as prednisone. These have shown equal efficacy when being compared to clobetasol. They are, however, associated with a higher incidence of some of those adverse side effects that come along with corticosteroids. Some examples of this would be Cushingoid syndromes, decreased ability for wound healing, osteoporosis, hyperglycemia, and then an increased incidence of cardiovascular effects. Steroid-sparing immunosuppressants can also be given to bullous pemphigoid patients. These are typically started along with a corticosteroid regimen. However, they allow the doses of corticosteroids to be tapered more rapidly in order to avoid those adverse effects that I just highlighted. And then in cases that are refractory to the treatments that we've already listed, more expensive therapies such as plasmapheresis or intravenous immunoglobulin can be considered. It should be noted that although it's not a direct treatment for bullous pemphigoid, prophylactic antibiotics such as tetracycline or doxycycline should certainly be considered. The rationale behind this is because of the fact that these patients have blisters, many of which erupt and become open wounds. We want to protect them from increased susceptibility to infectious agents. As far as osteopathic techniques go, lymphatic treatments, as well as those that normalize sympathetic tone, could certainly be considered. Examples of this would be the thoracic inlet techniques, pectoral traction, and then the one that is being demonstrated on screen is a supine rib raise technique. Next, we'll transition into discussing some of the ethical considerations, patient education, and then we'll move on to emerging research. As far as ethical considerations go, they're centered around the balance of maintaining the patient's quality of life while still managing her disease. And the fulcrum for this balance is ultimately the therapeutic agent that's chosen, as well as the modality in which it's prescribed. Factors in our case that need to be taken into account include the patient's health history. This is an 84-year-old female with multiple comorbidities, specifically her osteoporosis, as well as the history of non-metastatic breast cancer, both of which can be indeed affected by a steroid regimen. As far as living arrangements goes, it's known that she lives alone, but she is also dependent upon others for some of her daily activities. She also uses an electric scooter. So both of these facts bring into question her ability to remain compliant with a topical steroid regimen. And then, of course, the most obvious being the adverse effects of a steroid regimen itself. At the end of the day, patient autonomy is going to be critical, and this means that the patient is well informed of her disease as well as all treatment options, and then we would hope that she would make a collaborative decision with her physician, and if so desired, her family members as well. The International Pemphigus and Pemphigoid Foundation is an excellent source of patient education for bullous pemphigoid patients. They produce a wealth of information in regards to the disease, treatment options, and clinical trials, as well as providing support for the patients. Our patient was educated upon the basics of disease, as well as management of the symptoms, specifically that of wound care. And then she was also educated upon the risks of her corticosteroid treatment and then adverse side effects that she should be on a lookout for. As far as emerging research goes, most recent work has actually been directed at optimizing treatment protocols of known therapeutic options rather than the identification of novel therapeutics themselves. And this is for good reason. Sadiq and Zillikins, just this past year, published an article really highlighting the fact that morbidity and mortality of bullous pemphigoid is actually attributed to the therapy rather than disease itself. They also highlighted a former study in which the one-year mortality rates of oral corticosteroids were compared with that of topical corticosteroids. Those patients using an oral corticosteroid regimen had a one-year mortality rate of 41%. By comparison, those on a topical corticosteroid regimen, such as clobetasol, which we prescribed, had a one-year mortality rate of 24%, and this was found to be statistically significant. Comparisons like this really bring to light the importance of using a conservative treatment, especially with the vulnerable age population that is affected by bullous pemphigoid. It should be noted that in this study, the patients with their mortality were typically associated due to sepsis, pneumonia, cardiovascular disease, and stroke. Monoclonal antibodies are always a hot topic and are slowly finding purpose for treatment in bullous pemphigoid. Two prime examples are rituximab, which has successfully been used to treat diseases such as non-Hodgkin's lymphoma. This targets CD20 positive B and pre-B cells. In bullous pemphigoid, the goal would be to decrease the amount of autoantigens present by stopping the cells that ultimately produce them. Omalizumab is yet another monoclonal antibody, this one being successfully used to treat asthma. As seen on the screen, this monoclonal antibody targets the Fc epsilon receptor binding site on IgE itself. So once again, the goal in bullous pemphigoid would be to stop IgE from binding to the surface of these mast cells, decrease the amount of autoreactive IgE antibodies, and stopping that prodromal phase that we talked about from reaching its peak or possibly ever occurring. And lastly, we'll conclude with some salient takeaways that we learned from this process and want to share with our student doctors and student scientists in the audience. The first is that many of these skin disorders present in very similar manners, but they have unique differences that have to be elucidated. So a basic way to approach these cases is first to identify and examine the clinical manifestation of the rash itself. Always take into account the patient's past medical history and the overall picture of the patient as a whole. And then lastly, the specifics of the disease process, which would include mechanism of action as well as the cellular localization of where this damage is occurring. And then lastly, the second point we want to make, hearkening back to that balance of the patient's quality of life as well as the disease management. every therapy that we can prescribe has the possibility of an adverse effect. And so when making these decisions, it's always imperative to keep the patient in focus. This is our bibliography. And at this time, we'd like to acknowledge Dr. Hirsch, Dr. Dobson, Dr. Ballum, Dr. McCormick, Dr. Johnston, Dr. Johnson, Ms. Lori Fitterling, Dr. Schneirat, and Dr. Tyson for all their input and help in getting us to this point. And we'd like to open up the floor for questions.
Wow, that was so informative and way to go. First out of the gate. That is not an easy task. I am Dr. Hirsch. I'm going to be moderating today's Grand Round session. So what I'd like to do is, while they've been presenting, we've got questions coming up from faculty as well as questions online. So let's give them an opportunity to highlight even more knowledge about what we learned about today.
So we actually got a question before our presentation started, and the question is, why is bullous pemphigoid itchy? So the term that we would use for itchiness is pruritus, which is carried by unmyelinated, histamine-sensitive C fibers. And certain inflammatory mediators are released when mast cells are in the area, so the prodromal phase of bullous pemphigoid. For example, like histamine, cathepsin. There is different proteases, substance P, interleukins, prostaglandins that are released that will actually sensitize these neurons to react stronger. So when these neurons are sensitized in that inflammatory reaction, they will produce that itchiness that is seen clinically.
We also received a question regarding the reactivation of the VZV virus, which is the varicella, and in the PowerPoint it was mentioned that that causes shingles. Further on in life, over the age of 50 to 60, immune function generally declines, and therefore a person who has already suffered from a dormant VZV virus can have it reactivated, and then it can be manifest clinically as shingles.
Okay, and we also received a question that reads, when I think of IgE, I usually think of type 1 hypersensitivity. What classifies this disease as a type 2 hypersensitivity? So hypersensitivity classes are not determined by the antibody involved. They are determined by the antigen and the immune reaction. So in a class or type 1 hypersensitivity, we're normally dealing with a foreign antigen, whereas a type 2, we will be dealing with the self-antigen, such as our case bullous pemphigoid. Now, IgE is involved, or it is a key player in both type 1 and type 2, our case bullous pemphigoid. And actually, studies have shown that when administering IgE along with IgG to animal models, the severity of the bullous pemphigoid prodromal phase increased significantly. So yes, IgE is involved in this type 2 hypersensitivity.
Okay, so I had a question that asked, what is the etiology of bullous pemphigoid and why is it only seen later in life? So the etiology, as with most things, is not completely understood. MJ just talked about how it's an autoimmune type 2 hypersensitivity. There have been numerous studies that have shown a genetic component, so a link to an HLA2 or MHC class 2 MHC that is seen more prevalently in bullous pemphigoid. That includes DQB1 and DRB1. And then, as with most things, there's also environmental triggers that can happen, so trauma, burns, radiotherapy. And then there can also be association with different skin disorders like psoriasis, which can open up the access for antibodies to get into the dermal epidermal junction.
Thank you. Excuse me. I got a question about the S2 sound. So the question was, what's an S2 sound? In reference to a cardiovascular exam. So I'm going to talk about that. As per the link I found on auscultation of the heart sounds on UpToDate, this is what I'm going to tell you about the S2 sound. So it's produced by the closure of the semilunar valves, so the aortic and the pulmonary valves, and it's best heard in the left upper sternal border. So it's the closure of those semilunar valves, and it can be seen when a patient has pulmonary artery hypertension, so that valve is going to be closing under the high pressure. But in our case, our patient did not have the hypertension, so just wanted to point that out.
Okay, and we received a question. Why do people typically not show drug-induced eruption until they have been exposed for about 2 weeks? So this relies on a lot of different components, actually. The latency period between the drug initiation and that eruption, it can vary between months and years or more, and it really depends on the type of drug, the host reaction, if the patient's been exposed to this drug before, what other medications they take. So there's a lot of components to consider here. So just for an example, just according to some literature we're reading, with ACE inhibitors, sometimes we see an eruption 3 to 6 months later. With penicillin, it's 2 months to 3 years later, or penicillamine, sorry, 2 months to 3 years later. So it really does depend on a various list of components.
Yeah, I've got one here that, other than patient discomfort, is there any other risk to leaving this condition untreated? There are a couple. The biggest risk comes from secondary infection from excoriated blisters, leaving skin wide open to the environment. So all sorts of potential secondary infections can arise that way. The other part would be, excuse me, depending on the patient, a large amount of atrophic scarring from rupturing blistering as well. So it would, delaying of treatment would leave large patches of scar tissue, and especially in an 84-year-old patient with already thinner epithelium, that could be a dangerous combination.
I think we have time for one more question, and then we'll move on to the next group.
So we got a question asking about the causes of eosinophilia. So eosinophils play two roles: destroying foreign substances and regulating inflammation. And eosinophilia occurs when either a large number of eosinophils are recruited to a specific site in your body, or bone marrow produces too many eosinophils. So this could be caused by a variety of conditions, diseases, and factors, including parasitic and fungal diseases, allergies, skin disorders, toxins, and tumors. And some specific diseases are asthma, Crohn's disease, hay fever, lupus, and ulcerative colitis.
All right, so that concludes Group 1's presentation. There are so many excellent educational highlights, especially in the dermatology realm, as well as really taking into your account your patient's full, complete history, where they live, what medications they take. This is optimal when you're treating your patients. So it's very well stated. I learned a lot today. Thank you so much for your hard work and effort and being wonderful representatives of KCU. Let's bring up Group 2.
Hello. Yeah, that's working. Andy, is the new one anywhere special? Yeah. How do we turn this on? Okay. Hello. Okay.
All right, so group 2 is ready to go. It is my esteemed pleasure to announce group 2, presenting the case of an unresponsive 38-year-old man.
Okay. Good morning, everyone, and welcome to Group 2's presentation of a Medscape case, an unresponsive 38-year-old man. These are the members of Group 2 that have worked so hard to treat this patient and to bring this information to you today. My name is student Dr. Isaac Demke, and I will be presenting the history of the present illness as well as the differential diagnoses. Our patient is a 38-year-old man who was found unconscious outside of an apartment building in 35-degree Fahrenheit weather. Residents called the police, and paramedics arrived and brought him into the ER. Because of the patient's mental status at the time, he was unable to provide any information about his past medical history, his surgical history, his current medications, or his allergies. We were also unable to obtain an adequate social history or family history. The only information we have about this patient comes from the identification card found in his pocket, as no additional information was given by the onlookers at this incident either. Upon arrival at the ER, a base set of vitals were taken. In this table, we can see the normal reference ranges as well as our patient's values. His blood pressure was found to be 88/40, which is hypotensive. His heart rate was found to be 38 beats per minute, which is bradycardic, and his respiratory rate was 24 breaths per minute, which is tachypnic. An oral thermometer reading was unsuccessful at this time, so a rectal probe thermometer was used, and his body temperature was found to be 85.4 degrees Fahrenheit, which is hypothermic. An O2 saturation via pulse oximetry was unsuccessful at this time. We then proceeded to perform the physical examination of the patient. The general exam showed that the patient was unkempt with disheveled clothing and a faint smell of alcohol in his breath. At this time, he was unresponsive to verbal cues. A cardiovascular exam indicated that the patient had bradycardia, as stated previously. He had no murmurs, rubs, gallops, or extra heart sounds. A pulmonary exam indicated the tachypnea as well as rhonchi heard upon auscultation. He had a dullness to percussion in the right lower lung field, and no other abnormal lung sounds were heard. The Gastrointestinal exam indicated that his abdomen was soft, non-tender, non-distended, and normal bowel sounds were heard in all 4 quadrants. His extremities showed the skin to be very cold. His fingers and toes were cyanotic with delayed refill time. A neurological exam indicated an intact gag and corneal reflex, and at this time he became responsive to painful stimuli, and his pupils were round, equal, and reactive to light. There was no sign of head trauma. On the Glasgow Coma Scale, he was found to be 8 out of a possible 15. The Glasgow Coma Scale measures how alert and oriented a patient is. After looking at this assessment, we looked at the differential diagnoses that could be affecting this patient. We will talk about hyperkalemia, hypothyroidism, acute myocardial infarction, and hypothermia to come. If a patient presents with hyperkalemia, they will have abnormally high potassium levels in the blood. They will manifest with muscle weakness, stupor, and a coma-like state. This hyperkalemia is often induced by excessive alcohol consumption, which can lead to metabolic acidosis. This acidosis can lead to the tissues becoming ischemic, and the cells can then dump their excess potassium into the blood. This excess potassium in the blood can have several interesting effects on a patient's electrocardiogram. An electrocardiogram is a measurement of the electrical potential as it moves through the heart. Student Dr. Alex Curry later on in the presentation will give a more thorough demonstration and instruction of how to read and understand an electrocardiogram. For now, we're going to look at a few of these waves though. The first is the P wave, this is the QRS complex, and this is the T wave. In a hyperkalemic patient, this T wave seen here will be abnormally high or peaked. If the hyperkalemia becomes more severe, this QRS complex, which is normally tall and narrow, can become widened, as seen here on these abnormal EKGs. Here we see the QRS and the peaked T wave, and in a severe case of hyperkalemia, we see this widened QRS complex. The next diagnosis we're going to look at is hypothyroidism. With hypothyroidism, a patient will be manifest with abnormally low levels of thyroxine, which is secreted by the thyroid gland. Thyroxine is a metabolic hormone, meaning if we have low levels of thyroxine, we will have low body temperature. If the hypothyroidism becomes severe, the patient will demonstrate with a myxedema coma state, where they will have decreased mental status as seen in our patient, and decreased body temperature, and several other symptoms related to organ failure. Next, we will look at an acute myocardial infarction, or AMI. In an AMI, there is a blockage in a coronary artery depriving the heart of blood and oxygen. This can lead to ischemia and cyanosis of the tissues. There will also be several abnormal signs seen on an EKG, such as an elevated ST segment, which is the period between the QRS and the T wave. We will look at that shortly. An AMI will also demonstrate usually with tachycardia and hypertension, which are opposite of what we saw in our patient. CKMB, or creatine kinase, and troponin will also be elevated. The last diagnosis we will look at is hypothermia. There are 3 degrees of severity to hypothermia: mild, moderate, and severe. Based on our patient's presentation, we will be looking at moderate. In a moderate case of hypothermia, a patient will have an altered mental status, they will not shiver, and their estimated core temperature will be between 82 and 90 degrees Fahrenheit, or 28 to 32 degrees Celsius. They will have bradycardia and hypotension. Lastly, with hypothermia, there is an indicative J wave seen in the EKG, which we will look at shortly. After looking at these diagnoses, we decided to run a few labs and tests, the first being an EKG. This picture seen here is the patient's EKG, seen at 4 different leads. we can see several abnormalities in this EKG, the first being sinus bradycardia. We can look at this bradycardia by picking two repeating points in this graph, such as the QRS complexes. The distance between these 2 points is greater than it should be, indicating a reduced heart rate and bradycardia. Now also, all of the leads show this distinctive J wave seen after the QRS complex. This J wave, though not well understood, is very indicative of hypothermia, as I stated before. We also see the ST segment, which is between the QRS and the T wave, is higher than it should be or elevated, possibly indicative of an AMI. And we also see these peaked T waves, which is consistent with the possible diagnosis of hyperkalemia. We do not see any sine waves at this time. Next, we decided to order the CKMB test and a troponin T test. We are still awaiting the results from these tests, but if the values are found to be within normal range, we can most likely rule out an AMI as a possible diagnosis. We then ordered a portable chest radiograph, which showed a small consolidation in the right lower lung field of the lung, consistent with fluid found in that area. We then ordered a comprehensive metabolic panel, which tests the levels of 14 different compounds in the blood, testing the healthy function of several organs such as the liver, kidney, and pancreas. The patient's values were all within normal limits, including potassium, which rules out the diagnosis of hyperkalemia. The patient's blood glucose level was found to be 104 milligrams per deciliter, which is within healthy normal limits, indicating that hypoglycemia is not affecting the patient's altered mental status. Lastly, we ordered a complete blood count, which showed slight leukocytosis. This leukocytosis, in addition to the small consolidation in the right lower lung, the dullness to percussion, and the rhonchi heard upon auscultation are all indicative of a possible diagnosis of pneumonia. Finally, because of all of these symptoms and tests that we have seen, we came to the conclusion that the patient had moderate hypothermia from environmental exposure. We decided this based on the patient's body temperature, which is 85.4 degrees Fahrenheit, well within that range. The patient's tissues were cyanotic. He had bradycardia and hypotension, as well as the characteristic J waves seen in all of the leads of his EKG. Now I will turn the time over to student Dr. Alex Curry for the rest of the presentation.
Thank you, student Dr. Isaac Demke. I'm student Dr. Alex Curry, and I will be talking about the basic science, treatment, and ethical considerations for this case. Body temperature reflects the balance of heat production and heat loss. Heat is lost through 4 different avenues. The heat loss through infrared emissions, which is 55 to 65% of our heat loss, is radiation. Evaporation is the heat loss through evaporation of water through the skin or respiratory tract as you breathe. This is exacerbated in dry, windy environments. Conduction is heat loss through direct contact, which is the primary heat loss in water immersion, and convection removes warmed air from around the body, which is increased in windy conditions. Our patient was in 10 to 15 mile an hour winds, so convection plays a larger role in his heat loss. The body senses cold through cold receptors, which sends this signal from the periphery into the dorsal root ganglion, up through the spinal cord, to the thalamus, and then to the hypothalamus. The hypothalamus then stimulates the thyroid to release T3 and T4, thyroid hormones that induce metabolic events to increase the body's temperature. The adrenal glands are also stimulated to release glucocorticoids, which release glucose to increase metabolic activity of the body. The peripheral vessels are stimulated to vasodilate, which shunts blood to the body's core, increasing the temperature. However, alcohol causes vasodilation of these vessels, so our patient's hypothermia was potentially exacerbated by the fact that he had consumed alcohol. And muscles are stimulated to shiver to increase body temperature. Like stated earlier, this is a picture of an EKG, which is a graph that represents the electrical activity of the heart. This P wave here is small in our patient, but this represents atrial depolarization. This QRS complex here is atrial repolarization and ventricular depolarization. And then this T wave is ventricular repolarization. This J wave, although it's also called an Osborn wave, is a delay in the repolarization of the ventricles. So how do you normally stabilize a hypothermic patient? First of all, it's important to establish an accurate way to measure the patient's body temperature. Oral thermometers may report an error at low temperatures, so a rectal thermometer should be used. Wet clothing needs to be removed immediately, and intubation with an endotracheal tube needs to be considered depending on the patient's respiratory status. After initial stabilization of the patient, management of hypothermia depends on whether it's mild, moderate, or severe. Patients treated with passive rewarming need to have functioning thermoregulatory and endocrine systems and have efficient or sufficient energy stores in order to create their own heat. With passive rewarming, a patient is given insulating material and moved to a dry, warm environment. A disadvantage of this technique is that it's very slow to increase the body's core temperature, so this should only be used in patients with mild hypothermia. For moderate to severe hypothermia, active rewarming is used. First, active external rewarming, which increases heat through conduction. It's the application of heat directly on the skin through forced air warming systems, hot water bottles and heating pads, or warm water immersion of the hands and feet in 45 degrees Celsius water. These bring the newly warmed subcutaneous blood to the body's core. The problem with this technique is that peripheral vasodilation in response to being warmed may cause venous pooling and rewarming shock. Cold peripheral blood rapidly returns to the heart, leading to inaccurate temperature readings and subsequent inappropriate management decisions, and the patient's status might deteriorate before it gets better. Therefore, a more efficient active rewarming technique is active core rewarming, which is the application of heat directed to the body's core. This can be done through airway rewarming with humidified oxygen at 45 degrees Celsius through endotracheal tube intubation. This reduces respiratory heat loss through evaporation. And also with hypothermic patients, cardiac reserve is decreased, so volume resuscitation is advised. Heating the intravenous fluids to 45 degrees Celsius increases the patient's body temperature while simultaneously increasing their blood volume. Both of these techniques are minimally invasive and are recommended for most patients with hypothermia. For our patient, by moving him inside the hospital and out of windy conditions, his heat loss through convection was decreased. And then he was given a mask with warm air, humidified air to breathe. Warm intravenous fluids were administered, and a forced air blanket was given to cover his torso, and warm blankets were around his extremities. The EKG results resolved, and the patient's volume status and blood temperature returned to normal. He was admitted to the hospital for treatment of the right lower lobe pneumonia, which was treated with antibiotics, and was eventually discharged without any major disabilities. Regarding OMM, we focused on treating the pneumonia in this case through lymphatic treatments and myofascial release. These lymphatic treatments help increase the pressure gradients to increase lymph flow centrally, and the myofascial release of T2 to T7 will help relax the thoracic region. A treatment for hypothermia that has been recently researched is ECPR. ECPR uses an ECMO device to provide sufficient circulation and oxygenation of the blood. Special tubes called cannulas are put into the patient's blood vessels that go directly to the patient's heart or bloodstream. A pump pushes the blood to the ECMO, where oxygen and carbon dioxide are exchanged, and the blood is rewarmed and returned to the body through different cannulas. Rewarming rates of 8 to 12 degrees Celsius per hour are possible with the fastest rewarming devices. For ethical and legal considerations, due to the altered mental status of our patient, the attending physician was in charge of making our patient's medical decisions. The EMTALA Act of 1986 ensures public access to emergency medical care regardless of patient's economic status. So under this act, the attending physician was legally obligated to provide stabilizing emergency treatment to our patients, regardless of his ability to pay. And there was possibly a possibility that our patient was homeless, so the physician had a moral dilemma of potentially releasing the patient back into the environment that brought him to the hospital in the first place. For our patient education, we provided him with a list of local shelters and offered him help from a social worker and educated him about the risks of hypothermia. In general, if you're camping, hiking, hunting, or doing any outdoor activities in the cold, it's important to be prepared. So discuss with your physician any medical conditions or medications that may make you more susceptible to hypothermia. Most heat escapes from your head and your hands, so make sure that you wear hat and gloves and multiple layers before going out into the cold. And be aware of your alcohol consumption while being in the cold environment, as it may increase your risk of hypothermia. It's important to also know the signs to look for in yourself and others, such as shivering, which occurs in early stages of hypothermia but may cease in more severe cases. And presumably you know how your peers with you in the cold act like normally, so be aware of any changes in behavior or signs of altered mental status. Be observant for any of these signs that you see here, and get those suffering out of wet clothes into warm layers and evacuate the situation if necessary and possible. And some final thoughts from our talk here is that it's important to use a thermometer that's not an oral thermometer while treating a hypothermic patient. It's important to thoughtfully order appropriate tests to eliminate or support differential diagnoses. And as future DO physicians, we will treat our patients as a whole. So it's important to educate our patients in order to keep them happy and healthy and out of the hospital to avoid any future preventable hospital visits. We would like to thank everybody who helped us make this possible. This is our bibliography. And we'll move on to questions. Happy and healthy.
Wow, very well done, Group 2. Congratulations. Let's go ahead and open it up for some questions. Is there a particular side that would like to start? Yeah, here you go. Thank you.
Yeah. All right. So we got a really good question regarding other conditions that can cause J waves. So to remind everyone, a J wave or an Osborn wave is a positive deflection occurring between the QRS complex and the ST segment. It's the alteration or the delay in the initial phase of repolarization of the ventricles of the heart. So some other conditions that can cause J waves or Osborn waves are brain injury, subarachnoid hemorrhage, cardiopulmonary arrest from oversedation, or Brugada syndrome, which is another ECG abnormality associated with a high incidence of sudden death with patients with structurally normal hearts. And even though Brugada syndrome differs in respect to like the magnitude and the lead location of the J-wave manifestation, it's still considered a J-wave syndrome, like hypothermia.
Hello. We also received a good question on why the pulse oximeter did not work when trying to measure the pulse at the very beginning of the of when they arrived. So first of all, what is a pulse oximeter? A pulse oximeter is going to be just measuring the amount of oxygen in your blood and why it might be limited and didn't work while you were trying to take the pulse ox in this patient in particular. The pulse ox depends on blood flow. So a hypothermic patient is going to have most of their blood kind of cut off and shunted towards the core, and to keep the core of the body warmer. So the outer extremities will not receive as much blood flow, which is why the pulse oximeter did not work.
All right, so I got a question. What is the anion gap and why is it significant in this case? So early on with our patient, alcohol was smelt on his breath. And so alcohol, excess consumption of alcohol can decrease the respiratory drive, which can drive the cells of the body to go into anaerobic metabolism or to depend on an anaerobic metabolism. And this can lead to lactic acid buildup, leading to this anion gap metabolic acidosis, which was the type of anion gap that we talked about with our patient. And so if this is severe enough, the cells can become ischemic and release their intracellular components into the bloodstream. And so one of the main intracellular ions is potassium. And so if a lot of potassium is being dumped into the bloodstream, that can be considered hyperkalemic. So early on for our patient, this had to be differentially diagnosed because of the potential overconsumption of alcohol.
All right, so one of the questions was how long after myocardial infarction do you expect to see elevated troponin levels? So serum cardiac troponin levels rise as early as 3 hours post AMI and can remain elevated for as long as 10 days in the case for troponin I, or up to a few weeks post AMI in the case for troponin T. And this is actually the advantage in using measuring cardiac troponin levels versus cardiac creatine kinase levels, because in the case of creatine kinase, it only remains elevated for around 2 days, which leaves a smaller window of opportunity to detect AMI.
So another question we received was, can an AMI be ruled out with one result from troponin or CKMB? And the guidelines on myocardial infarction have changed recently. AMI has been redefined in terms of cardiac markers, and now we look for an increase in cardiac troponin on at least one occasion, and also an increase in CKMB on at least 2 occasions with a rise and fall pattern or greater than twice the upper limit of the reference range on one occasion. So we're looking for both.
Hello, okay. My name is student Dr. Joanna Chuang, and I got a question on the Glasgow Coma Scale and what it is. The Glasgow Coma Scale is a scoring system for the level of consciousness after a traumatic brain injury. It is to gauge the severity of the brain injury and is often tested in emergency departments and intensive care units. It is composed of an eye response, verbal response, and motor response exam. These responses are scored and summed into the Glasgow Coma Score of the patient. It is measured on a scale from 3 to 5, with 3 indicating severe brain injury and 15 indicating a conscious and alert patient. And this leads into another question we got about how can an unconscious patient respond to, how do you measure the Glasgow Coma Scale if the patient is unresponsive? And we can measure them because most of these responses are based on painful stimuli. So even if the patient is unconscious, they will still be able to respond to the painful stimuli and be scored using this test.
Yeah, good morning. I'm student Dr. Jonathan Colgrove. I got the question, how can hyperkalemia be related to muscle weakness? So if we remember back to Isaac's, hyperkalemia is just an excess of potassium. And so if you have an excess of potassium outside of the cells, then it will not allow potassium inside the cells to leave and ruin the resting membrane potential. And so you can't excite the cells as much. And therefore, it's difficult for the muscle to contract. And so the excess potassium leads to the muscles not working as well.
All right, good morning. I'm student Dr. Addison Durham, and I have a couple questions here. So the first one is, what is the importance of the intact gag reflex in an unresponsive patient? Student Dr. Joanna touched on this a little bit, but essentially with that, you're looking for the activity of the brainstem. So there's several tests that can be performed. You have the pupillary response to light, the corneal reflex, motor responses to pain, any kind of respiratory effort the patient is making, and then obviously the cough and gag reflexes. So that's simply used to measure the activity of the brainstem to give a Glasgow Coma score. We also got at what level or at what value of potassium will you typically see an ECG change or an EKG change. We've had several discussions about that, so I'll keep it brief. But the level should be, if you have blood concentrations greater than or equal to 7 milliequivalents per liter, you will get some changes on the ECG.
All right, so another reason a gag reflex is probably pretty important for us to consider is we need to make sure that patient's able to protect their airway. Also, we want to make sure if we can assess, is there a risk for this patient having any kind of aspiration component, which is most likely why, in this case, a chest x-ray was ordered, a patient was found unresponsive. We need to make sure that this patient didn't aspirate. Y'all did a very, very great job. Thank you so much, both groups, for your time, dedication, and commitment. You are extremely wonderful representatives of KCU, and I can't wait to see you on your medical adventure. So thank you all so much. I hope you have a wonderful day.